Good morning, good afternoon. Firstly, I'd like to thank to the organization for his invitation to this meeting, especially to Dr. Guillaume. It's really a pleasure to be here. I want to show you our experience in La Fe Hospital about the treatment of loss of domain in large hernias and the use of preoperative techniques like Botox and pneumoperitoneum. It's a long experience of 2 years. These are my disclosures. Loss of domain hernia involves physiological alterations and changes in the quality of life, respiratory problems, changes in defecation and urination, and negative economic repercussion. A Mexican plastic surgeon, Tomás Ibarra Hurtado, reported in 2009 the Botox application on abdominal wall is feasible and possible. He achieved a significant decrease of the transverse hernia defect, as well as increase of the length after open abdomen management, applying the toxin in lateral muscles of the abdominal wall. Many working groups like mine have adapted these results in this experience in abdominal wall repair. As you know, Botox causes a chemical denervation and transient flaccid paralysis, and the top of the effect of this toxin is in 3 or 4 weeks, and then decreases over the following 5 months. Therefore, Botox increases the abdominal cavity prior to hernia repair and optimizing preoperative period. But an interesting question would be, is botulinum toxin enough to prepare loss of domain hernias? The answer is no in our experience, because the benefit of the Botox alone is not enough in some cases. We need to combine another technique like pneumoperitoneum. So the goal of pneumoperitoneum is to create a controlled progressive distension of the abdominal wall, and the abdominal cavity needs to get used to the hernia content. To make a plan and evaluate the needs of each application, it's mandatory to have a CT scan where we can obtain several parameters like volumes and diameters related to the hernia and abdominal cavity. Hernia diameters are useful to know the possibility of Botox application, and volumes useful to know the possibility to apply mainly pneumoperitoneum. In our experience, Botox is applied under outpatient basis, and we use 500 units of Dysport infiltrated in 10 points, and using electromyographic and ultrasound guidance according to Ibarra's protocol. The 3 lateral muscles are located, in this video you can see, by ultrasound, and we check the viability of the injection with electromyographic guidance. 5 points are identified on each side of the abdominal wall, 2 points in the mid-axillary line between the rib margin, in the upper iliac crest, and 3 points between the anterior axillary and mid-clavicular line. And we managed to identify the best point according to the maximum contractility wave, improving its effectiveness, especially in patients with muscular denervation, atrophia, or fibrosis. But it's interesting to know the volume and the duration of the pneumoperitoneum. In my hospital, the total volume is in function of the hernia volume and the individual patient's tolerance, but the formula is 3 times the hernia volume value in cubic centimeters, approximately a liter a day. And the duration is variable depending on the global volume of air, but approximately it's around 10 days. This video is interesting comparison between pre and post treatment, combining both preoperative methods. You can see sagittal and coronal images of CT scan, so as increase of the length and decrease of thickness of the three lateral muscles. And you can see also the abdominal cavity reabsorbs the hernia content. A new space is created due to the effect of the progressive error. Our experience in figures, 105 cases with combination of both methods. Important to remark the most frequent technique was components separation, anterior and posterior, and ribs stopa technique. After a follow-up of 38 months, we found an 8% of recurrent. I think is an acceptable figure treating these complex patients. But apart of loss of domain hernia, another indication of Botox would be the possibility to change a technique like component separation for another less morbid repair using the neurotoxin. We can take advantage of Botox, try to achieve a down staging of the repair. For this reason, we did a prospective comparative study of 80 patients with midline incisional hernia, double 3, according to the European Hernia Society, and the inclusion criteria was transverse hernia diameter between 11 and 17 centimeters. Therefore, two groups, open anterior component separation, 40 patients, versus Botox and after ribs stopa repair, other 40 patients. You can see the interests to find out the results in terms of facial primary closure, complications according to Clavi and Dindo classification, and the recurrence. And the results were better in the group of Botox and ribs stopa. Finally, I want to show you the algorithm of my group. It's a dynamic protocol, which it has been modified step by step, depending on our experience for last years. CT scan mandatory to calculate the diameters and the volumes, and then to calculate the Tanaka index, and we can have a Tanaka index less 20% and maximum transverse hernia defect less 11 and 12 centimeters. We don't need to perform any preoperative techniques, but Tanaka index less 20% and maximum transverse hernia defect 11 and 12 centimeters over. We use botulinum toxin in outpatient management to try the down staging of the repair. On the other hand, Tanaka index over 20% or loss of domain hernia, according to many authors, we need botulinum toxin and progressive pneumoperitoneum. 30 days before surgery, we apply Botox, and in 10 days, roughly, we apply pneumoperitoneum. Remember, we use 3 times the hernia value in cubic centimeters. And finally, we need to check the differences in volumes and diameters by a CT scan and pulmonary function test the day before definitive repair. Thank you very much. Bye.